The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining us for the Addressing Vaccine Hesitancy and COVID-19 webinar. I am Amber Freeman, the Training and Technical Assistance Coordinator with the Connecticut Coalition to End Homelessness. So today we have a very informative webinar for you. But before we begin, I just want to go over some housekeeping. So because this is a webinar, you all are all muted. However, you can type any questions that you have at any point inside of the questions box, and we'll be sure to get to them most likely at the end of the webinar, but we'll try to answer as many questions as possible during as well. Also, this webinar is being recorded, and the recording as well as the slides will be available in our webinar library, and you will also receive the recording in your email. So for today's webinar, we have Marwan Haddad, who is the Medical Director at the Center for Key Populations with Community Health Center. And we also have Casey Harding, who is the Director of Center for Key Populations with Community Health Center. So at this point, I am going to hand it over to Marwan so he can start us off with what you need to know about the COVID-19 vaccine.
Hi, everyone. I'm actually going to take it from here. As Amber said, I'm Casey Harding. I'm the Director of the Center for Key Populations here at Community Health Center. And as a start to the presentation, which Marwan's not moving along for me, I added a couple. We realized after we did a few of these presentations for other folks that we hadn't included any of our CHC slides. So because we're limited on time, I'm not going to review them, but I did want to include them so that you could get a view of sort of where we are, what our mission and vision is, how many sites we have. You can see we have about 100,000 patients. And, you know, we work in clinical excellence, research and development, and also, you know, this section of education and training. So, you know, every time we introduce ourselves as the Director and Medical Director of CKP, we also have to answer the question, what the heck is CKP? So again, I don't have to review this thoroughly, but this gives you an idea of the Center for Key Populations and what it focuses on at CHC and why it's so important. And within the vaccine world, I think it's become even more important because we really have an avenue to vulnerable populations that might get lost in the shuffle. And so that's one of our focuses right now. So moving right into vaccine hesitancy, I think, you know, we kind of renamed this away from vaccine hesitancy because we don't want to focus on that, but we want to focus on where it comes from and what we can do to foster a more open environment to talk about vaccines. And so you can see the World Health Organization describes it as a delay in acceptance or a refusal of the vaccine despite the availability. So you have access to it and you can get the vaccine, but you still make a decision not to. And we talk, and we'll talk a little bit more in the next slide about complacency, convenience, and confidence, and the role that those play in working with people to accept vaccines as a healthy option for them. Next slide. I think we're having some technical issues. So we'll start out with confidence and what we need to build confidence in. And remember, when we're talking about the hesitancy in accepting a vaccine, we're not just talking about ourselves, our patients, we're talking about our family, our community members, our churches. And so we're all having these really large discussions around vaccines. I had a birthday party for my niece.
I'm sorry, Casey, I'm just going to interrupt you. I just don't have control. I can't really move the slides over. So I'm wondering, Amber, if you can take back control and then you can proceed.
Perfect. So again, yesterday at a birthday party, you know, all of our conversation really revolved around, you know, the new vaccine from Johnson & Johnson is coming out and who had side effects. And, you know, this is a lot of what we're talking about. So we want to make sure that we always have the appropriate information. And so when we talk about the 3 C's, we're talking about confidence. Do we have trust in the vaccine and the provider? Complacency. Do we or our family or whoever we're speaking to, do they understand the need for the vaccine and the value and impact it could have on their life? And then the convenience. Is there access? And we're going to talk a little bit more about each one of these. So the next slide talks about confidence. And where does the confidence come from? Well, you have to have faith in the vaccine. You have to have faith in the provider giving the vaccine, and you have to have faith that all the rules have been followed. So you can go back one, yeah. So are the vaccine options safe? Have they been proven effective? And are they appropriately provided to you? So this gives you a little bit of an idea. And I apologize if some of you have been on other webinars we've done, because some of these are similar, but this is sort of the scientific process. And we have such a history of vaccinations, successful vaccinations, that we knew when COVID happened exactly what needed to happen, what the steps were, how long we needed to develop each step, who we had to test everything on. So in terms of the safety, really, we don't have any question on that. On the next slide, we talk about the effectiveness, and this is always one of my favorite slides, because when you look at this, next slide, when you look at this vaccination, even compared to a flu vaccination or to the varicella chickenpox vaccination, this one has an higher efficacy rate. So we know that this vaccine is effective. Is it provided appropriately? Again, we have more knowledge about freezers and temperatures and trucks and how they transport things. And because we really needed to make sure that all of our I's were dotted and all of our T's were crossed. And you can see that little diagram when it comes from the factory, where it goes in the truck, how it gets to our site, what we have to have on our end to provide storage, how long we need to take it out of the freezer before we can give it to someone, how long it can be out of the freezer and still be viable and effective. So all of those things are really important, but we have checks and balances that assure us that they're always provided appropriately. So next slide is, I think, about complacency. And this is more about perception, and it can be your own perception, it can be the perception of the people around you. How important is this vaccine? Some people have said to us, well, everybody else is getting it, I don't need to. Why should I suffer the side effects or whatever? But the important thing to remember is that it protects you, but it also protects the people living in your home, the people you're in contact with, and your community. So there's a little bit of what I call an immunity bubble that you can form by getting vaccinated, the more people who are vaccinated. So having those conversations about the need for the vaccine and why it might be important to a person who, you know, a lot of people, when we first gave the vaccine, even healthcare workers said, well, I don't really go in anymore. I do a lot of telehealth visits. And we said, but if you're vaccinated and we need someone to come in and start giving vaccine to patients, then we have that option. If you're not, it's less safe for our patients. And so looking at all of those things can really influence those around you. And then lastly, I forgot the last one, so I need the slide. Confidence, complacency. Next slide, Amber. Oh, I think we skipped one. Oh, and accessibility, obviously. So, oh, I think we did skip a slide, but anyways, accessibility has to do with where you get the vaccine and who can get the vaccine. So I'm going to pass it off to Dr. Cadet.
Yes. So next slide, Amber. So yeah, so the third C is convenience, right? Which includes accessibility as part of the convenience. And so this is just to sort of talk to you about the phases. We know where we are with the phases. So some of the updates on the phases are going to be this, right? So we know the phase 1A initially was all healthcare workers in congregate settings, which homeless sort of, long-term care facilities and first responders. Then next slide for the 1B, we opened that up to 75 plus all congregate settings, which included all homeless shelters. And then since then, we have then subphased it to adults over 65 plus. And you can move on to the next slide. Now, as you know, as of March 1st, as of today, we can go to 55 plus all educators and child care providers. And we're going to, and the governor's office has decided to keep going down by sort of, every 10 years in the next every few weeks to get to hopefully by April or May to everybody to open it up. But within that, there are also going to be some focus on people who are sort of register on the social vulnerability index that's based on the CDC, that basically says those limited access communities, those individuals who are high risk but are less likely to access, there needs to be a little bit more of a focus to be able to get these vaccines out to those communities. And so so now, hopefully, with all the different clinics that are being stood up for vaccines, we'll start to also at least a portion of all these vaccines to be focused looking at the communities who are at the highest risk. Next slide. So, it's hard to talk about vaccine hesitancy, right, without really talking about mistrust of the medical establishment, particularly among communities of color. So obviously among communities of color, especially among the African American and Black communities, we're looking, we have a very long history of centuries of that sort of date back to the time of slavery. And as we all know, slaves were used as subjects of very abusive, involuntary medical experimentation. And in many ways, that has continued in many forms over the many decades and centuries. So we don't have to go that far back when we look at the Tuskegee syphilis study that many of us, if weren't aware of before, are now very much aware of, which is good, because I think we need to be able to talk about these to be able to understand where generationally, right, communities of color have this mistrust from the medical establishment. And so the Tuskegee syphilis study started to recruit back in the 30s African-American men in Alabama for people who might have had bad blood. And that's what they sort of used to term it back then, people. And they recruited 600 men, around 400 with syphilis and around 200 without syphilis. The issue here that happened is no informed consent was ever given for this. But the biggest problem, right, was in the 40s. When penicillin became available and became known to be a treatment for syphilis, that this treatment was not offered to these individuals in the study. So they just continued to monitor them without giving them the treatment, now, despite the fact that there was treatment, and around 130 men died from syphilis complications. Many more suffered, and obviously spouses became infected, children became born with congenital syphilis, and this just was stopped in the 70s. So we're not going too far back here. On top of all that, there's just persistent health disparities, whether it is among the Black community, whether it's among the Hispanic community, whether it's among the American Native and Alaska Native sort of communities, that these health disparities are very, very, very sort of clear, and have been clear for many years and decades, but very little has been done to really change that. And I think hopefully now, with COVID just shining more of a light of these disparities, that we're now finally, I think, universally talking about this, and hopefully things will start to change over time. And so I think everybody needs to be talking about these health disparities, this medical mistrust, and start to sort of just acknowledge it and start to build trust again among the communities. And to do that, we need to, first of all, acknowledge it. We need to listen to these communities, listen to what their needs are, what their concerns are, and to start to build that trust back up again. This is just to show you that COVID specifically, when we look at these disparities, you can see here whether you're American Indian, whether you are Black or African American or Latinx, that compared to whites, you are around 1.5 to 2 times more likely to actually develop COVID as a case. You are just around 4 times more likely to be hospitalized with COVID, and you are around 2.5 to just under 3 times more likely to die from COVID. All right, and this is all disproportionately affected, right? So compared to the percentage of each of these communities, compared to the proportion that they are in the general population, they are affected at a much more higher rate. Right? So that's what we mean by disproportionate. So let's say, among the Black communities, around 12% of the population, yet they are affected at a much higher percentage rate compared to whites, and similarly to Latinx as well as American Indian. Next slide. So I'm not going to go too sort of detailed into this. This is just to further emphasize that when we look at vaccine rates specifically, so separate from the other medical mistrust, when we look at vaccines overall, we know that there is higher mistrust when it comes to vaccinations. Let's say the first one was looking at flu vaccines, and that the rates of flu vaccine uptake among Blacks and Hispanics was much lower than whites, despite the fact that they perceived a higher risk of disease for the flu. Similarly, you can see here the Kaiser Permanente study, 42%, Blacks were 42% lower odds of being vaccinated than whites. And then when you look at vaccine rates overall, not just for flu, in this National Health Interview Survey, you could see that Blacks were 24% lower rates than whites, and Hispanics were 19% lower rates than whites. Next slide. This is the newest study that have come out of Kaiser Family Foundation. They continue to do interview surveys, and this was specifically on the COVID vaccine. And so they did a survey of around just over 1,500 people, of which around 310 were Black. And when you look at this, around 164 were Black women, 146 were Black men. And the surveys that the results I'm going to show you was specifically on the Black sort of respondents. Just to sort of put it in perspective, just under 300 did not get vaccinated yet, did not get the vaccine. So only 4% of the Black population that was interviewed here was vaccinated at this point. So this one just to show you that overall, 1 in 5 Black women say that they will definitely not get the vaccine, right? So if you look at this overall, around 14% of all Black adults said they will definitely not get the vaccine. 8% would get it only if it's required. 43% were wait and see, and around 32% would get it as soon as you can. So only a third of all Black adults more or less said that they would get it as soon as they can. So we have a lot of work to do here. And when you break it up between Black men and Black women were more likely to be sort of suspicious of this vaccine than Black men. Next slide. And I'm hoping that they're going to do the same with the Hispanic population and others as they get the survey. But this is what they just sort of brought out specifically to the Black population who were interviewed, Black adults who were interviewed. This just to sort of show you that despite the optimism over the vaccines, there is still a lack of confidence and trust in the healthcare system. So you can see here overall, 65% of Black adults were optimistic. Right, and that sort of came down the same between Black women and Black men, but sort of more Black women were frustrated, 60%, about the current status of the vaccines in the U.S. In terms of the confidence, around half overall were not confident that the distribution of the vaccine is going to take the needs of the Black people into account, right? And then almost 60% among Black women and just under 50% for Black men. And that the trust of the healthcare system, and this is huge, right? That they would do the right thing, that only some or almost none of the time for them, right, was half. That's crazy to me, right? That 1 in 2 Black adults don't believe that the healthcare system that they have currently will do what is right by them. All right, next slide. And this is just to sort of show you the majorities of Black women express concerns over the safety, effectiveness, and possible side effects. And that's sort of true across the board. So this wasn't really giving us a comparison towards, other communities. But the two big things here is, to me, that the takeaway was that the COVID vaccines are not as safe as they are said to be, right? Again, this speaks to the mistrust that is there. 80% of Black women and 70% of Black men thought that the vaccines were not as safe as we are saying they are, and that they are not as effective as that we're saying that they are, right? Around 70%, 75% of Black women and just under 70% of Black men. Next slide. And I think this is the last one yeah, so there we go. And so then this is just more data to show that, and the reason why I put this in here, this was around the H1N1 vaccine. Remember the avian flu that came around? So we had started to add the avian flu on top of the flu shot that we had. So this was just to show you that in this particular survey, Black participants were the most likely ethnic and racial group to report having tried to get the vaccine, but found it unavailable. So this again speaks to access. So this is not only about hesitancy and mistrust, but even for those individuals who wanted the vaccine, they had a hard time finding it. So all the more reason for us to be able to make sure that when people want to say that they want the vaccine, that it is easy enough for them to get it. Next slide. All right, this is back to Casey.
So again, we don't want to give you too much information that's redundant, but talking about the common concerns, we've talked about it in, you know, in some ethnic groups, but really there are concerns all around, and we want to again make sure that the messaging that we're giving is accurate and that it's given in a way that people can understand or can evaluate, because we want everybody to make their own healthcare decisions. So, you know, looking at the safety, looking at the necessity of some people saying, you know, disease is an organic state, it takes care of itself. I actually have someone in my family who says if I'm meant to die from COVID, I'm going to die from COVID. So, you know, that is a reason for some hesitancy. We talked a lot about distrust, but there's distrust in other areas that are related to just the actual vaccine and the inadequacy of research. Looking at the healthcare system and thinking, well, big pharma is trying to sell me another vaccine, you know, those kind of things, and having the conversations around, you know, what are the potential areas to be mistrustful versus the potential impact on your life. Lack of information. So, you know, we all went through this election where there was this bombardment of news and different things, and you really had to evaluate what was important and what wasn't, and where you wanted to get your information. And it's the same thing with vaccinations. Do you get it from the Today Show? Do you get it from CNBC? Do you get it from NPR on your drive to work? And what is the information that's being given? Is it accurate? Is it what you need to make this decision? And then societal influences. I had a really nice conversation with a friend of mine who said, I don't want to hear from Dr. Haddad that he got the vaccine. I want to hear it from my pastor, because that's who's important to me. And so are we having these conversations in social settings that are important to people? And, you know, and how do we know what's important? Who's important? And then obviously there's always going to be religious and personal choices, and we want to be really respectful of those while still providing information that could help someone make a decision. Next slide. I think the other thing we're having a lot of conversations, and this is probably really important to you all, is how to discuss the vaccines in a way that's open and healthy, but that also gets across the urgency of getting the vaccine while it's available. So, you know, one of the big tips that came out of the research that's already been published is trying not to come from a position of authority. It's very hard for someone to express concern or ask questions when they feel like there's a power differential. And obviously there always usually is a power differential, but if you can mitigate it a little bit, if you can do it in an environment where you're creating an open space, you can see I gave you a bunch of tips here, but really acknowledge the concerns constructively. You know, don't judge a choice like, oh, of course, your priest says not to get the vaccine, that's just nuts. You know, oh my gosh, I didn't realize that in that particular religion, there might be some things that you had to think about. Could you tell me more about it? So really kind of practicing how you have those discussions. Vaccine hesitancy, and this is a big one, and this is something that I had to learn early on, and I think we all do. It doesn't, just because someone is asking a question or making a decision that's not necessarily the one you hope they will make, it doesn't mean there's a lack of information or that they're, you know, that they're vulnerable to misinformation. Sometimes it means they're just making a different decision. It doesn't mean, though, that you can't continue the conversation and say, wow, I've never heard that position before. Tell me a little bit more. And again, use positive messaging to have a discussion. And we always want to, and again, this is very hard in healthcare where we're so committed to this vaccine, highlight the fact that this is a thoughtful decision-making process, and it doesn't have to be done in this moment. If you're having a conversation and a patient is maybe, or a patient, a family member, someone is feeling stressed out and hesitant to get the vaccine, it may be where you say, would you mind if I called and talked to you again tomorrow? I understand today we're not going to move forward with this, but is there another time we could have a conversation? So leave it open that this is something people may need to think about and process. And then, you know, the knowledge piece, I think if you have the knowledge, if you have the insight, if you can, you know, give the information, that's really important. Try to include some science in it. not a ton, I don't think, and really talk about the evidence. Well, I know someone has told you that this vaccine is ineffective, but I just want to tell you, according to the studies, it's 94% effective in this case, or, you know, have those things at the ready, and then be able to discuss really intelligently relevant risk and benefit. Yes, there could potentially be a risk, but the benefit is this. The risks are, you know, side effects, but we haven't seen that in however many doses we've given, that kind of thing. And then this, again, we just had this staff meeting this morning where we talked about this. Having, you know, staff training has to be ongoing and continuous. I know it gets boring to listen to Dr. Haddad and I talk about this, but there's changes. Every time we do this presentation, there's a change in it that's a little bit different. There's a different message we can help with. And so I think it's really important to encourage staff to just sit and listen and kind of gather information. Next slide. And then I just wanted to throw out a couple, and I won't go through these, but you can see on February 24th in the US, we gave 1.45 million vaccinations. Every time I say something like that to my kids, they're like, so everybody's vaccinated. Oh my gosh, that's so many people. And it does seem like it should be, but obviously we know we have millions and millions of people to vaccinate, but we're doing well. We're doing better than most. If you go to the next slide, this is a bunch
just to interject here, Casey. So just to give you a sense, most experts and epidemiologists say that we need to get to around 4 to 5 million vaccines a day to get ahead of this when it comes to sort of herd immunity and get ahead of the epidemic. So we're doing well, but there's still a lot of room for us to grow.
And part of that was not having enough vaccines, and part of it is not having enough Dr. Haddads to get them in the arms. So, so just again, I don't have to read through these, but it gives you an idea in the US how many millions of people have received one dose, how many received both doses, and then looking at Connecticut. So 17% of Connecticut residents had at least one dose and 8 had 2 doses. So that gives you an idea of how far we have to go. And remember, these numbers are also only eligible patients. So once we get into those bigger categories that we've talked about, we're gonna have to do a lot better. The next slide is, again, just a couple statistics that I thought were interesting. So Connecticut's doing a great job. We've used 83% as of February 24th. 83% of the doses that got sent to us were put in an arm. 75% in the US were put in an arm. So that's, that's a good, that's a good number. We're doing great. And then you can see, I just, to highlight why we're talking about this, because 7,595 people in Connecticut have died of COVID and 503,000 across the United States. And those are just staggering statistics that we've never really seen before. So, I wanted to include those. Next slide.
All right, so we're getting now into the actual COVID vaccines and what information do you need to sort of know about all of them. The last thing I'm going to say about this hesitancy in the discussion is, as sort of Casey said, our role is going to be just providing the information, and we need to make sure that we're doing it on a number of different levels, right? Some people want to hear from the doctor, some people want to hear from the nurse, some people want to hear from the pastor, and so it needs to be a multi-pronged approach to be able to get to everybody. And so I think the more people are out there talking about this, the better in terms of just addressing the questions that people have and potentially, convincing them one way or the other to decide to take the vaccine or not. All right, so as you probably heard, we used to have 2 authorized vaccines for emergency use by the FDA. Available now, as of Saturday, we have a 3rd, Johnson & Johnson. And I want to say at the outset, and I will keep repeating this over and over again, because I think this is going to be important messaging, that we can't compare the percentage of effectiveness between Moderna and Pfizer to the newer vaccines that are coming down the pike, like Johnson & Johnson and AstraZeneca and so on and so forth. We would be comparing apples and oranges because the studies were done under different circumstances. So in other words, when Moderna and Pfizer first got studied, it was studied before the COVID variant started to become more dominant, whereas Johnson & Johnson and AstraZeneca were being studied during the time when the COVID variants were available. And we'll talk a bit more about that in a bit. What I want to say at the outset is that all these vaccines Moderna, Pfizer, Johnson & Johnson, so far, all of them have protected 100% prevention of hospitalizations and deaths for those individuals who got vaccinated in the vaccine arm versus in the placebo arm, right? So those who got the vaccine in these trials, almost all of them did not get hospitalized and did not die compared to those who didn't get the vaccine. All right, that just needs to be clear that all these vaccines are extremely effective of preventing hospitalizations and deaths. All right, we can talk about the nuances of the difference in a bit, but I think this is the biggest message we need to send out to everybody, to you guys and everybody else, when it comes to looking at these vaccines. So Moderna and Pfizer, they are currently 2-dose vaccines, right? Moderna is 2 doses, 28 days apart. Pfizer is 2 doses, 21 days apart. And all of these trials, Moderna, Pfizer, Johnson & Johnson, were huge trials. We're talking about tens of thousands of people enrolled. Compared to other vaccine trials, these are huge. So when people talk about, oh, this was done so fast and how could they have done it so fast, no corners were cut. The amount of people that got enrolled in these studies were tremendous compared to the previous, vaccine trials for other vaccines. And when you look at the diversity of these trials, also they did an amazing job looking at them. Around half were women. Around 10% were Black or African American. Around 20 to 26% were Hispanic or Latinx. Around just under 1% were American Indian. They had a good sort of a fifth to a fourth who were 65 or older. Many had comorbidities. And so really the diversity of these were amazing. And when you looked at the breakdown, we can go to the next slide. In terms of its effectiveness, let's take Moderna, for instance. It was around 95% effective in those up to 18 to 64, and around 87% who were 65 years or above. And even that 86% was probably higher because the number of people who got infected who were over 65 was such a low number that it just statistically looked like this low. But I would take 86% anytime. These are really very high effectiveness results compared to other vaccines. So, and unfortunately, we started it so high that any new vaccine coming down the pike, like Johnson & Johnson, when we hear, oh, 66% effective, just starts to sound that there is a huge discrepancy, when at the end of the day, it really is not going to be that different, and we will talk about that differences in a bit. So let's talk a little bit about side effects. Side effects in these cases, these vaccines are very reactogenic, meaning that they are designed, they just happen that they're designed, they're going to cause these side effects. And that these side effects mean that the vaccine is working properly and that your immune system is being sort of triggered to mount those antibody responses that we want. So that way, if you do come across and you see COVID in your everyday life, that you are protected. You've got those antibodies to protect you against the COVID infection. I hope that makes sense, right? That when we say, I got a headache, I got fatigue, I got muscle joint aches and pains, I got fever and chills, that many people do get them, especially after the second shot, or especially if you had COVID and then you get your first shot. We know that people are going to mount these responses because your immune system has already been primed, either by that first shot or by the infection. So when you get that second shot, or that shot after that infection, your immune system is just now revved up and you've mounted that great response that we want to be able to fight off that COVID infection, right? If you see it in the future. So I hope that that's clear. In terms of injection site reaction, it's sort of like a tetanus shot, a little bit worse, I think, than that tetanus shot. It would cause that sort of muscle ache in your arm. In terms of the allergic reactions, I know that there was huge concerns around this, about anaphylaxis, but when you look at the actual numbers compared to the millions of vaccine doses that have gone out, they're fairly small. So for Moderna, after over more than 4 million doses, only 10 cases of anaphylaxis occurred in the US, right? And 90% of those anaphylaxis occurred within the first 15 minutes to 30 minutes of getting the vaccine. So this is why we make people with, history of anaphylaxis wait around 30 minutes. So that way we want to make sure that if you're one of those rare instances that you're going to get it, we can give you that EpiPen and go with it. Nobody's died from this. In terms of the Pfizer, vaccine, again, 95% effectiveness. Pfizer is the only one currently that is indicated for 16 years and older. All the other vaccines currently are 18 years and older. We'll talk a little bit later about the children, but with Pfizer, you could give it to 16 or 17. Same thing, high numbers of side effects, but those side effects are a good sign, right? We need to tell people that you shouldn't be scared of them, right? If you get the side effects, they tend to kick in within the first day or two after getting the shot and last for a day or two. After I got my shot, is not the first one, but the second one, I was out for a day. I sort of like laid in bed. I got up and did whatever I needed to do. And then the day after that, I was back to normal and good to go. And I actually was very happy. I mean, I was sort of not so happy for the 24 hours of the way I was feeling, but internally I was happy to know that my immune system was responding to this vaccine, and I know that I'm now sort of protected from that response. And similarly, very rare allergic reactions that occurred among Pfizer as well. Next slide. So, I talked a bit about this, but, whether it's messenger RNA, and now with the Johnson & Johnson, we're using this virus vector to sort of, trigger our responses. The whole issue here is that we're not presenting the whole virus or parts of a live virus or parts of a dead virus, right? We are presenting, sorry, you can't present parts of a live virus, but you can either present parts of a dead virus or the actual live virus itself, right? These aren't what we're doing. We know through lots of historical science that were sort of done. I mean, if you remember the SARS back in 2002, 2003, this is the same coronavirus, very similar to it. That's why it's called the SARS-2 versus SARS-1. So we have so much information from back then around what the coronavirus looks like, what the SARS virus looks like, and what we have to target. And we know that we can target the spike protein, this one small protein that will help prevent an infection. And that is what we were able to hone in on almost immediately, which was why we were able to develop this as quick as we did, because we already had the science behind it. And so the messenger RNA or the new viral vector does not give you anything that's going to cause your body any problems. This does not change your own DNA, doesn't come sort of near sort of incorporating itself as part of your DNA. The messenger RNA or the virus itself are inert, and then they just simply dissolve in your body and disappear. Next slide. So hopefully that is clear to people. I know that we started talking about messenger RNA, so people thought, oh my God, this is genetics. It's going to change things within me. It does not. That's a myth. We talked about it was rushed and it isn't safe. Let me just tell you that with vaccines overall, they're rare that you get these long-term effects, right? So to get this authorization, the emergency authorization, we knew that if we study this vaccine for the first few months, that in general, most of the effects that we might see from a vaccine occur almost immediately within definitely the first couple of months. And so we have that data. We have that data, and the majority of these vaccine responses were really just those side effects that we talked about, right? That they're reactogenic, the side effects that we want to know. So the safety of it has been more or less assessed. Of course, there's still time for the full approval to happen, and we're going to be looking at from a long-term effect. But again, vaccines rarely cause long-term effects. Usually, if there's going to be any effects from the vaccines, it happens in the short term, and we've got great data on that already. We talked about its effectiveness. We talked about it not changing your DNA. It does not give you COVID. It doesn't have COVID virus in it. It will not give you COVID and will not turn any of your PCR tests for COVID testing positive. All right. So also be clear on that because people are thinking, well, I'm going to get the COVID if I get the vaccine. That's not the case. It doesn't contain egg protein. It's not been used by stem cells. There was no other types of sort of concerns in terms of how it was developed. We talked about the side effects, right? It causes severe side effects. And please remember that it's rare that people get severe side effects. You might get knocked out, for a day or two because of it, especially if you've had COVID before or after the second vaccine. But that's good. Again, I want to repeat that means that your immune system is doing what it should, and it's mounting that response against COVID. And the whole rumor around it might make women infertile, that was rumor in the internet that spread. That is not true. We've vaccinated many women. Women are getting pregnant. There's just no truth, in fact, around that whole concern around infertility. Next slide. so other issues and concerns. So we talked about pregnancy and breastfeeding. So as you know, it's hard to study pregnant women from ethical sort of standpoints. And so women who are pregnant were not studied in the big trials. However, in these trials, women who were enrolled in these trials, definitely some got pregnant. And there were really no effects that we saw during the pregnancy and post delivery for these women in terms of these trials, as far as we followed so far. The American College of Obstetrics and Gynecology and other big organizations have come down and said these vaccines are not a contraindication in pregnancy or in breastfeeding women. All right, so and that the fact that they've come down and said that it actually is more of a risk for a pregnant woman to get COVID infection compared to getting the vaccine, because if pregnant women are more at risk for severe disease and hospitalizations if they got COVID compared to if, let's say, from what we might not know from the vaccine. So many women, please, you don't need to review this with the healthcare providers. If you've done your decision making and you want the vaccine, you can sign up and come in and get your vaccine. But if you want to talk to your providers, please do, in terms of what the pros and cons are of getting vaccinated during your pregnancy or if you're breastfeeding. If you're immunocompromised for various reasons or you're living with HIV, it's not a contraindication to get these vaccines. The issue here is, as what we've known all along for the same as other vaccines, you might not mount that same response of the antibody response because your immunity is lower compared to those who don't have an immunocompromised condition, right? And that just sort of makes sense. But any response that you might mount may be better than no response at all for that. So again, make your decisions, and keeping in mind, this is not a live virus, right? We worry about people with immunocompromise or with HIV in the past, right? Is if we gave them a live virus that they might get infected because of the live virus because of their low immunity. This is not the case here. This is not a live virus. For children, we said only Pfizer is for 16 and 17-year-olds. Moderna and Johnson & Johnson are for adults. But there are now ongoing studies of looking at 12 to 17-year-olds. And we'll know a little bit more in the near future around these vaccines, especially if we're going to be looking at whether this is going to be a yearly vaccine. It's important for us to know whether it's going to end up being safe in children, and that's being investigated at this point. We talked about if you already had the COVID before, should you get the vaccine? Guidelines are yes. Natural immunity against the COVID gives different people different responses. Some people mount a very good, robust response. Others might not mount as much of a response to it. But we know that these vaccines mount a great response almost uniformly from patients overall. There's always there are exceptions to that rule, but overall we know that the vaccine gives a more consistent and persistent response for the most part across the board compared to if you just naturally got infected compared to others who may have gotten infected. The issue is, we talk to say if you're acutely infected, you're still in that isolation period, you can delay getting that vaccine till after you're no longer in isolation, and you can delay it up to 90 days after you got infected, because you most likely have the immunity within that 90 days. But you can get it at any time after your acute infection. And if you're one of those who received monoclonal antibodies to treat COVID, you should also delay 90 days. We said that vaccines will turn your tests positive if you've missed the second dose, right? So right now, Moderna and Pfizer, we told you, is 28 days and 21 days. You can go up to 6 weeks after your first dose to get the vaccine. So if you didn't get it exactly in 21 days or 28 days, it doesn't matter. Get it as soon as you can. But do not miss that second dose, right? Please do not miss that second dose. So far, all the science that we know so far, we need the second dose. It's not been studied as a single dose. And regarding, let's say, it's still, if you got Moderna, you should get Moderna as a second dose. If you got Pfizer, you should get Pfizer as a second dose. In those rare circumstances, they may say, all right, if for whatever reason you can't access Moderna again, you could get Pfizer, the same type of vaccine, right? Messenger RNA vaccine for messenger RNA vaccine. But recommendations are still stick to the same the same vaccine that you got the first time around. Next slide. I do want to talk a little bit about COVID variants because we've been hearing a lot about them. And I just want people to understand that these are not, these naturally occur, right? Viruses naturally mutate. And the more we allow the viruses to continue to replicate and infect others, the more chances we're giving them to mutate. And eventually they're going to mutate into a variant that may not respond to the vaccines that we may have. They may mutate to a point where they may become more infectious, which we know some of these variants are, or they may mutate into a variant that may be more deadly, let's say, or more severe in terms of causing the symptoms. So what we need to do about controlling these variants is to get people vaccinated as much as possible so that the replication in our communities and in our countries are not as rampant. Because the more times that these are replicating, the more likely we're going to get these variants, and we're never going to get rid of this COVID variant overall. And that's true also when you look at it globally. We can control it in the US, but if 3/4 of the countries don't even have access to the vaccines right now in the world, that variants are going to start to develop, and we're going to get it back in the US, right? So we need to think about this not only for our own communities, but also think about it globally. So talking about globally, right? The UK variant, the South African variant, the Brazil variant, we've heard about these, but it doesn't mean that it's the UK that developed this and so on and so forth. We're going to see the California variant, we're going to see the Connecticut variant, we're going to see the US variant as well. So again, control of replication is what we need to do, and one of the best ways we can control that is to get the vaccine out to as many people as possible. So far what we know about these current variants, that they are more infectious, they spread more easily and faster. Right? Well, we don't know yet, but we're starting to hear perhaps that they may be more severe or more deadly, but more to come on that, and we need to keep looking at this. The other concern, in terms of the next slide, please, is that do the current vaccines protect us against the variants that we know are out there? So Moderna and Pfizer, since they developed their trials before these variants came about, so they went back and studied small number of people, and they showed that at least the current vaccines that we have is effective against the UK variant, maybe decreases its effectiveness against the South Africa variant, but still, because they're so effective in terms of developing these antibodies, that they're still effective overall against these variants. But they're looking into adjusting the vaccines, sort of what we do with the flu shots, but more effective in terms of, as we know the new variants are coming back, we can sort of adjust these vaccines, and maybe we're looking at boosters on a yearly basis. Still not clear for that. Next slide. So that takes us to, sorry, we needed to update these, that this is no longer pending, but Johnson & Johnson has now been authorized for emergency use. And what's good about Johnson & Johnson are a few things, right? First of all, Johnson & Johnson was studied during the time when the COVID variants were rampant in the UK, in South Africa, in South America. And so that's why we're seeing that these percentages, right? So we don't see a 95% effectiveness. We're seeing a 66% effectiveness overall against moderate to severe COVID around 14 to 28 days after the shot. But this is only one shot. So this is amazing for some of our communities, which we might have trouble bringing back again for a second shot. And so this is a single dose so far. And this is, again, studied in 44,000 people. Again, huge trials, multiple countries, especially in countries where there were these high rates of these variants that are now more dominant. And it was 85% effective in protecting against severe disease, right? 72% effective in the US, 66% in South America, 57% in South Africa. But again, we know that it protected against 100% hospitalizations and deaths in all these cases. So again, Johnson & Johnson, right? Please don't compare 66%, 72% versus 95% for Moderna and Pfizer, because the trials were done under different circumstances. And if we redid the trials for Moderna and Pfizer now, we might see the same very high effectiveness, but maybe not like Johnson & Johnson, but maybe not as high as 95%. But again, like I said, no hospitalizations, no deaths, and it seemed to protect on those severe severity in those countries where we see these variants going along. The other big advantage to Johnson & Johnson is that it just requires regular refrigeration for up to 3 months. So this freezing and the deep freeze for Pfizer and all that is not required for Johnson & Johnson. So again, one shot, refrigeration only, very effective against these variants, and no hospitalizations or deaths under anybody who's gotten vaccinated under these circumstances. So please get the word out that when Johnson & Johnson becomes available, that this is not a vaccine that is going to be substandard compared to Moderna and Pfizer, because I think we already are hearing those. And to me, I would take any vaccine that is available to me, and maybe one shot is better than two shots for those who are scared of needles or scared of side effects. We're also hearing overall that Johnson & Johnson, although it was also reactogenic, but not maybe to the extent that we're seeing Moderna and Pfizer as well. So you might also get a little bit less side effects with Johnson & Johnson compared to Moderna and Pfizer from that reactogenic perspective. And last, this is I think the last slide here, AstraZeneca, the trial is still going on in the US, but it has been approved in UK and in other countries. And again, same thing, the effectiveness is looking similar to Johnson & Johnson because again of the variants that is around during these trials, but also very effective, 0 hospitalizations and deaths in those who were fully vaccinated in these trials. And the storage similarly is regular refrigeration. So again, we need all these different vaccines to be able to get to all our communities, whether it's rural, whether it's our homeless, whether it's on so forth, but also globally. Think about this globally as well. You know, do you have the deep freeze capabilities in rural Africa, right, or in rural Asia, or in these sort of cities versus not? And for us to be able to vaccinate the world to get ahead of this pandemic is what we need. And so this is all extremely important for us to be talking about. And I think now, hopefully, we've got around 10 minutes left for any other questions that may have come in that we didn't cover.
Or are you all sleeping?
No, we actually did have some questions that came in, and I can go over them for you.
Sure.
Let me, as I pull them up, let me just say that was a great presentation. I know I learned so much.
Thank you.
So let me pull up some questions for you. All right, so we have several. So can you talk a little bit about the efficiency in terms of contracting it and spreading it after someone has been vaccinated, as well as how long does the vaccine protect you?
Yeah, great question. And questions we don't know the answers to yet. We are starting to see, first let's take the question about, does this protect me from spreading it to other people, right? And currently we don't know that. Definitely Johnson & Johnson has shown early data to show that it might stop asymptomatic infection, right? So let me, take one step back. These trials looked at, especially Moderna and Pfizer, but some of the other ones, looked at preventing symptomatic infection. Right? Which is why we can say that it stops people from becoming symptomatic with COVID and stops the severity of disease. What they did not do is test everybody all the time, whether they had symptoms or not, to see whether it also prevented asymptomatic infection, meaning that you don't have the symptoms, but you carry the COVID virus. And we know that asymptomatic infection is one way that we continue to transmit the virus to others, because we're not feeling sick, we don't know we have it, and we spread it. So that's something that wasn't looked at. They're starting to look at it now, and it seems that it is signaling that it is also decreasing asymptomatic infection, which then may translate to also decreasing transmission. But all those data points need to be tied together and looked at a little bit more. So there are indications that it does do that, but we don't know 100% yet. So we have to say that currently, we definitely know that it's going to prevent you from getting infected and symptomatic, and definitely from hospitalizations and deaths. But please continue to practice, masks, social distancing, all that stuff, because we still don't know whether you could transmit it to others if you do end up getting it. We might know sooner than later, hopefully, but for now, please continue to sort of protect that. What we also don't know is how these variants are going to act, right? So will we be able to get the asymptomatic variants and still spread those variants to others, so they may be more infectious as well? So all the more reason to continue to sort of do the physical distancing until we know more about all that's coming down the pike. Oh, and the second question is how long it lasts. Again, because we don't have years of data with this, we do know that most likely for sure that the vaccines will protect for at least 90 days, like natural infection does. It may be for longer, but it may be for years, it may be just for a season, and we'll know a little bit more about that. But either way, with these variants, it may require just a booster every year to try to cover any new variants that may be sort of circulating in the world and in our country, you know, from that front.
Okay, thank you. So what if someone doesn't have any side effects, and then after the second dose, they may start getting side effects? Does that possibly mean that it's not working for them?
So you know, I realize that by emphasizing that side effects means great immune response, people are saying, well, what if I didn't get the side effects? Does it mean I'm not getting a good immune response? I'm assuming is the corollary to that, and that's not the case. We don't know that either way. We know that a good percentage of people did get side effects, more so if you were younger, because of your just stronger, more robust immune response, more so if it was after having been infected with COVID or after the second dose because your immune system is primed. But it doesn't mean that if you don't get these symptoms or you don't get strong enough symptoms that you haven't mounted a good enough response either. Because as we saw in these trials, the response was so dramatic across the board that it protected people whether they got these side effects or not, right? So just keep that in mind. Doesn't mean that. But if you get it, I don't want people to get scared of, oh, something went wrong with the vaccine. It just simply means that your immune system is really saying, hey, I get this. It's sort of like when people get the cold. I can get the same cold as Casey or as Amber, but I might manifest my fever and my symptoms a lot stronger than Casey. But doesn't mean that both of us are not fighting off the cold and we're not getting rid of the cold equally the same amount. It just depends upon how our immune system sort of responds to that. Hopefully that answers the question.
I think you did. Okay, so we have a question about vaccinations being, let's see, I'm sorry, I'm trying to read all of it. Being that the vaccinations only just occurred and they're saying that it doesn't cause infertility, but it's something that needs to be observed long term, could it potentially be passed down genetically?
Sorry, what could be passed down genetically? You mean so just to be clear again, the vaccine does nothing with your genes, right? It does nothing to sort of screw up anything about your genetics at all, right? So something needs to change genetically in your body for you then to be able to pass it on genetically, let's say to your offspring. To your kids or to your babies, but nothing like that is happening at all, right? I know, unfortunately, that when we hear RNA or DNA, we start to worry about, oh my God, we're putting in an RNA in me and that's going to sort of mess up with my own genetics. It does not, right? It's just a vehicle to present the spike protein to our body for our immune system to respond against the spike protein. These RNAs just dissolve. They just disappear from our body. It never gets integrated as part of it. And that's why it just doesn't get passed on to anything or anybody. And which is why it doesn't cause any, there's no reason why it should cause any type of infertility whatsoever.
Okay. All right. And we have a couple of people that are asking if you can speak a little bit about the newness of the mRNA technology. They've had, some concerns about that.
Sure. So in the past, vaccines always struggle to figure out, so what do vaccines do, right? Vaccines want to mimic the actual infection for our bodies to mount the antibody response that we need to protect us the next time, right? So we know in general, if you get the measles once, you're not going to get it again. If you get the chickenpox once, most likely you're not going to get chickenpox again, right? Because once we see the infection, we mount the response. That response lives in our body and in our memory, immune cells. So that way, if we see it again, we mount that response and protect ourselves from it. So what vaccines do is to present to our body to mimic the infection. So in the past, we used to be able to either give a bit of a live virus, not enough to get us infected, symptomatic, but enough to sort of mount our immune response, or maybe parts of a dead virus or bacteria to say, hey, this is the part that we need to protect ourselves, the immune response that needs to protect ourselves, so we're presented as such. Messenger RNA as a technology has been being developed for many, many years now. And actually it was used before now for the Ebola vaccines and a few other sort of vaccines as well. And it's just a way it's a really easy and effective way to present that part of the virus or bacteria that we know we need to mount a response against to protect ourselves. So this time around, for instance, messenger RNA is just coding for one protein. That's all it is. That protein generally does nothing else in our body, but it is seen as a foreign protein because it's not a protein that we develop ourselves, which is what we want. And then our immune system will develop that antibody against that protein in and of itself only. So that messenger RNA is just a different way of presenting one part of the virus. Instead of giving us part of a dead virus or giving us part of a live virus, is presenting one protein for it to sort of develop against. Similarly, the virus that so the Johnson & Johnson presents what we call an inert adenovirus. So we're using an actual virus itself that doesn't really cause any problem, that doesn't get us sick. Right? Adenoviruses makes colds, right? Generally cause cold. But this adenovirus that they're using, we've been using for a long time as well, is an inert adenovirus, but it presents that spike protein as well within it. It carries that material, the genetic material to present to our body for that spike protein to present. I hope I'm not getting too technical, but this is technology that we've been using for a long time, and it's really amazing technology and safe technology for us to use. And safer for our bodies, I think, in many ways, than rather giving us a live virus, let's say, right? From that.
Great, thank you for clarifying that. I'm going to ask you one more question. So first, let me tell you that we have several people that are responding saying that they've learned so much and they were on the fence about getting vaccinated, but now with this information, they feel as though they're ready to. But when they do go forward and get vaccinated, can they request which vaccine they actually want to get?
Good question. Currently, we can't. Only in that, if I have to go into the logistics, and that's even way above my pay grade, of how these vaccines are being distributed from federal to state to hospitals to community health centers, it's really an operation that's mind-boggling. And then the way they're being presented, Pfizer comes in these small bottles that are 5 to a bottle, and then they come in packets of 90. Moderna comes in packets of bottles that are 10 that come in 100 sort of, boxes of 100, and you can't break those up. And as we sort of enter them into the vaccine clinics to sort of say, to give you Moderna and then to give somebody else a Pfizer and then give somebody else a Johnson & Johnson, starts from a logistics standpoint become very, very difficult. So a lot of the vaccine clinics, what they're doing is they're saying, we're doing Pfizer or we have got Moderna. Sometimes we don't know until last minute which vaccines we're going to be getting from the state as well. What may eventually happen is that when you make the appointment, we might know beforehand, I don't think we're there yet, that, if you have an appointment with this vaccine clinic, we know that the vaccine clinic has Pfizer or Moderna. But currently, I think it's just going to delay your appointment to get the vaccine if you're going to try to hold out for a Pfizer or a Moderna, or you might not even get the answer as you're making the appointment, whether it's going to be Johnson & Johnson, Moderna, or Pfizer. So my advice is get whichever vaccine that's there. Get vaccinated as fast as you can, as quick as you can, with whichever vaccines that you're going to get, because they're all going to equally protect you against the severe diseases and hopefully stop the spread once we know a little bit more about the spread, which is looking like it may very well stop the spread.
Great, thank you. That is what is most important. So thank you. I see we are actually over our time. We may have lost Casey, but thank you so much, Dr. Haddad. Thank you so much, Casey, if you still are there. Thank you for the viewers that are here. This information will be available. It will be on our website as well as email to you, the slides as well as the recording. You have Dr. Haddad's and Casey's email address right there on the screen. And if you have any other questions or concerns or anything else related to training, you can reach me actually at training@cceh.org. So again, thank you all so much and take care.
Thank you.
Thank you.